Good morning. We are going to start. So introduce ourselves. We are moderators for this session. My name is Dr. Angela Muhozia from Tanzania, and I'm here with
Dr. Abel Mwale from Zambia.
Thank you, Dr. Abel. So I'll start with our first speaker. This is none than other Dr. Caroline Colbert. She is a current president of SASSA. She has 16 years experience in anesthesiologist. She has worked both in public and private sector, but currently practicing in private section. She has a passion for both teaching, innovation, but also in leadership. Dr. Caroline, we are very eager to hear from you and to learn from you. Okay, let's give our hands for Dr. Caroline.
Thanks very much. So I'm actually the past president. I think if our president were here, he would have. Thank you for the introduction. So yes, I'm going to be speaking on innovating for the future, rather than just what the future of innovation looks like. I do have some disclosures. None of them are going to mean that there's any conflict for this presentation, but what's important to note, please, is that none of the product, literature, or content shared are endorsed by SASSA. I do receive grant funding, but I'm not in any way funded to present today. So let's start at the very beginning with Simon Sinek. He's a favorite of many of us, I think, and he speaks about the golden circle. People don't buy what you do, they buy why you do it. So if we look at the why, the how, and the what, it's about communicating from the inside out. And this is where we realize whether what we're doing actually brings purpose to our space, and whether that purpose can be enacted into a process and ultimately produce results or have impact. And this is critical, whether you're an innovator, whether you're an educator, or whether you're just getting up in the morning and trying to get through your day in the most productive way. It all depends on what your why is. So why do we innovate? Do we innovate because we can, or do we innovate because we should? So innovating because we can often means we've got the technical capability, funding, the individual need or the desire. You're able to just do it because you want to. Perhaps the commercialization and industrialization process is already enabled. There may be an established market that you're feeding into. Or alternatively, we're doing it because we should. There might be a dire consumer pool or an industry push, and that better shouldn't be optional. So there may be a right to access some better technology or innovation in a system. There may be environmental impact demands saying that it's not good enough what we were doing before and the impact needs to be reduced. There may be sustainability demands, but we need to start looking at why we're doing it. Because we can or because we should. You see, it's not the strongest of the species that survive, nor the most intelligent, but that who is most responsive to change. And we saw this during COVID. So what this taught us is that everybody is an innovator. We don't all get it right all the time, but if you pressure a system enough, it will innovate, and it's necessary, and whether the change is comfortable or uncomfortable, it has to happen. So let's define the objectives of innovation, the how and the whom. What's the problem presented? Who or whom does it impact? Does the impact even warrant a solution? Some of what you see sitting on the shelves of the CSIR or an academic biomedical engineering department really should never have been invented. It's fun, but is it ever going to actually achieve impact? Who's the consumer? What's the extent of the problem? Is the solution feasible financially? It might be a wonderful plan, but it's just never going to be affordable. Does the proposed solution even solve for the problem? Will the consumer ever adopt the solution? And will it be relevant for everybody? We're seeing a lot of technology-centric innovation, and a lot of technology-centric innovation that hasn't actually adapted with time, and the laryngoscope is an excellent example of that. More than 150 years ago, a metal spanner was used successfully to serve a purpose for technology. Nobody really wondered whether it was comfortable to hold or whether it was nice for the patient to have it stuck in their mouth, but it was tech to technician transfer, and it was effective, and it has been, which is why we still have it on the table. So if we use that as the basics for unpacking the types of innovation, you can define innovation and the types in a number of ways, but for this example, we'll say you've got a sustaining version of innovation in laryngoscopy, a radical version, an incremental version, and a disruptive version. And if we innovate in a sustaining manner, we just change the bulb intensity, and it's great. It maintains a position in the existing market, and it improves the outcome. If it's a radical innovation, we see what happened with video laryngoscopy, which created entirely new markets. It harnessed non-consumer markets, which was phenomenal. Incremental innovation would be usage of disposable blades to just steadily build on the space. And a disruptive innovation would be a completely novel approach to the same piece of technology. It often challenges price points, and it often really upsets the existing products in the market. But why should we innovate if it works well already? And we must innovate because, unlike before, where we had very technology-centric innovation, we've now moved towards a far more human-centric approach to innovation. Rightly so, because your user interface and your user experience now matter. And the market is far more informed, the demands are far greater, and we understand that to truly have impact and achieve our purpose, we need to talk to the consumer, and we need to improve on the user interface as well as the user experience. And so people need to be in the middle of that. Human-centric innovation requires human connections for human solutions. You can't have a solitary industry push, or you're never going to have a technology acceptance model that works. People just won't use it. Consumer needs need to matter, and the dynamic nature, specifically in the healthcare space, means that technology needs to be agile. It needs to be able to pivot, and it needs to be able to listen to its market. Silo engineering is long outdated. So cross-networking of skills and actual lived experience, and creativity, which I'll speak about in another few slides, that gives you the depth of collaboration required to have fit-for-purpose pieces of technology. We need dynamic culture and ecosystem consideration. The people, the process, the politics, and the place need to be considered in the healthcare system specifically. And through universal solutions to universal problems, we can start looking at a more holistic approach. If we don't appreciate the change in learning and education, our technology acceptance model will fail every time. Your current teenager has a 3-second bandwidth. They are nano learners. How many of the pamphlets that you'll see outside in trade take that into account? That we don't want a hard copy that we're going to have to go and read through. You've got 3 seconds to grab them, and if you don't get them in that 3 seconds, you've halfway failed. So we spend a lot of time designing the bridge, but not quite enough time thinking about the people that have to cross it. So what needs to change for us to take that into consideration? So I've reframed how we should approach or look at technology and innovation, and I believe we should be looking at it, is it cost effective? Is it human-centric? Is it eco-friendly? And is it ethical? So frugal innovation has to be a focus. We can't censor innovation because it doesn't come from a wealthy environment with lots of tech to support it. We need open tech sharing platforms and cross-sectional IP sharing. We need to be thinking about future people and understand the change in the tech acceptance model. Future problems can only be addressed if we think about future people. Hand-to-mouth innovation needs to be replaced by longevity of impact. So if we innovate only for today because of a problem we see now, we're going to have very wasteful usage of that technology because it won't be sustainable. It has to be eco-friendly. The impact for today may have harmful outcomes tomorrow, and then was it really ever worth it? And no solution is truly authentically human-centric if it's harmful to the environment. Patients can hinder progress. I'm sorry, patents. Patients can too. There's a corporate vested interest in most technology and development that can really stifle growth. And all solutions need to be considered before we start censoring innovation. And this is a reality in the space. Not being able to talk amongst ourselves because of the risk of IP protection infringements often really stifles growth. So there are a number of different ways to look at a technology acceptance model. This looks very complicated, but the reality is the user going to adopt it and continue to use it? But then I pose this to you: what if your user's not yet born? How are you going to plan for a technology acceptance model? And not all human beings are created equal. So if you are innovating something for a 16-year-old boy, which 16-year-old boy are you innovating for? This is totally dependent on the human interface. We can't have tech-to-technician-focused transactions, and we can't have a short-term impact with a single intervention. We need long-termism, and the only way to really take that into consideration is to look at who is the human being that I'm actually innovating the solution for. A single sector design input limits the impact because it limits your focus. So learning and innovation go hand in hand, but the arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. So let's look at this from a different point of view. What if we future people-proof our innovation? Who is the user to interface? What impacts that user now and tomorrow? Why is that solution necessary for them? How will the process impact the user? And will tomorrow be better because of the solution you devise today? You see, human-centric innovation is a very well-described process, but you've got to keep going round and round in that circle with the person in the middle, defining, ideating, prototyping, testing, and empathizing. If you don't really think about the person, the product is of no use to them. The Precipice is a book written by Toby Ord, and he is part of the Future Human Institute at Oxford, and is very controversial. It's a hard read because it's uncomfortable. But he asks if we're innovating for the right problems, and they did a terrifying study, collated masses and masses amounts of data to look at what the threats were to civilization, what was going to kill us in the next 100 years, anthropogenic versus existential risks. You know, most people think it'll be a nuclear fallout, it'll be a war. And to note specifically, this was written pre-COVID. And this is a basic summary of the threats to us as per Toby Ord's book. What I want you to look at is that pre-COVID, they estimated that engineered pandemics had a 1 in 30 chance of killing us, dead the whole civilization in 100 years. Unaligned artificial intelligence was a 1 in 10 chance risk. Other anthropogenic risks were very much present, as were existential risks, but you were as likely to die by your own hand. I say that as humanity. We're killing ourselves off. And this is data that wasn't difficult for them to put together, but why are we not looking at this and listening to this and putting in the regulatory networks and nets to catch these from becoming a reality? We still have time to intervene here. So we are the problem in many instances. So are we innovating responsibly and ethically? Are we doing good better? Just because we can doesn't mean we should. You see, there's a massive regulatory lag in innovation with extensive loopholes. Finance is prioritized over future, and effective altruism is key. William McCaskill looks at this through his foundation as well, and he speaks very frankly about future people and what we need to be doing today so that the universe tomorrow is reasonable, because the responsibility sits with us. We need to align our moral compass with environmental impact, and we need to be very careful just to leave human autonomy unchecked because of how linked to AI it is. Is it a curse or is it a cure? Well, I asked ChatGPT what it felt about itself, considering we had a 1 in 10 chance of being destroyed by AI, and its interview was quite frightening. I got two pages of answers from ChatGPT on the ethical concerns, the risk of job displacement, security risks, the risk of bias and fairness being falling by the wayside. There were control and governance issues, dependency on technology, economic inequality, a loss of privacy, the unintended consequences that can be difficult to manage, the concerns with ethical use in research. Navigating these challenges will require collaboration between technologists, policymakers, ethicists, and the public to ensure that positive outcomes are aligned with societal values and needs. We're losing sight of the human being in all of this. Even ChatGPT, AI itself, knows there's a problem. So is environmental impact as big of a problem? Well, 4 to 5% of the global greenhouse gases are health systems related. I'd say there's a problem. So we have a carbon footprint we probably cannot ever avoid having, but can we start treading a little lighter in that footprint? So when we innovate, who should our target market be? William McCaskill again says, what do we owe the future, and that there's no time left to waste. Future people must count. There could be an awful lot of them, and we can make their lives better. What will these people look like? We don't know, but we do know that they're going to be older, and we do know that they're going to be quite urbanized. So are our innovations speaking to that? What will these 16-year-old boys' problems look like in 20, 30, 40, 50 years? The average startup innovation takes 7 to 10 years to come to fruition. So every idea you have now, think about, will we still need that in 10 years? When it's commercialized. And we need to keep humility alive rather than hubris in innovation. We can't be elitist, we must open source as much as we can, and we must remember about the Medici effect, which speaks to the diversity required in teams in innovation. It was a concept that Franz Johnson put into his book and republished an expanded version, and it was based on what happened in the Renaissance period, where concepts were central to improved innovation, and he looked at the need for diversity of culture, professions, specialty, demography, geography, and lived experience. The Medici family were a very, very wealthy family during the Renaissance period, and they realized that sometimes if an artist and a surgeon and a poet had coffee in the same space together or shared a meal, wonderful things happened, like Leonardo da Vinci. And so they took all of those highly creative people during that time, and they created hubs for them to come and sit and have conversations. And suddenly we had this incredible amount of innovation. So we need to remember that creativity and collaboration and sustainable growth give us the most wonderful intersectional innovation. And this is what's going to solve our problems, guys. Talking to each other talking to people that don't usually sit in the same room as us. And then we can redefine the objectives of innovation. Is it sustainable? Is it impactful for tomorrow? Is it ethical, cost-effective, and inclusive? Is the technology acceptance model relevant for future people? Is it eco-friendly in addressing the cause as well as the effect? Is it immeasurable in its improvement? And will the solution be globally relevant? And if you remember your why, that future people must matter most, none of the solutions you come up with will ever be wasted. So in conclusion, human centricity and relevance prioritize human need. The collective and staying connected to the need for your design is vital. Inclusive innovation is mandatory for holistic solution derivation. Remember about effective altruism. Remember about sustainability and prioritizing for tomorrow. Remember about future people versus hand-to-mouth individual needs for today. And long-termism is really important, looking beyond the bigger picture. Because if you can be accountable in the way you innovate today, you'll have a sustainable society tomorrow. I'll leave you with the greatest shapers don't stop at introducing originality into the world. They create cultures that unleash originality in others. Thank you.
Thank you, Dr. Caroline, for that interesting talk. Yeah, so why are we innovating? And for who? Is it going to have an impact? So all these are very, very important questions. Are we making for ourselves? But she gave us a very important information that we have to make it for the future, for it to be sustainable. And the rest of the point that she presented, let's take it to our practice as doctors, as anesthesia, so that we can change our society. Our next speaker is a South African name. I would rather she introduce herself because I am from Tanzania, so I don't want to miss it. But she is a public health specialist. She's a director at the Charlotte Makerere Academic Hospital. Her interest is in data, decision making, and the health system strengthening. Please come for the next talk.
Good morning, everyone. My name is Tshegofatso Maimela. I'm from Charlotte Makerere as the Monitoring and Evaluation Director there. And I'd like to speak to you around health information systems. But I've got a particular lens towards them because I think sometimes when we speak about health information systems, we generally seem to be drawn to the technology of health information systems. And I would like to perhaps discuss the culture in organization in adopting health information in order to advance their decisions. Okay, so I'll start briefly with an overview of how we understand health systems, and just to talk briefly around our current health landscape, particularly in the resource-limited context. And then I'll speak around the role of health information systems in supporting service improvements. Now, whenever you find any public health practitioner, I'm sure they will draw you to this health system strengthening framework that was developed by the WHO in 2007. And it underpins the inputs that are required in order to get to the outcomes, really, of improved health, a responsive health system, one that reduces financial risk and, of course, demonstrates some level of efficiency over time. And you can see that the inputs and the pillars that are on the far left are service delivery, the platform on which the service is delivered, the health workforce, the information that's available around the health system in totality, the medical products, as well as the vaccines, technologies, the financing mechanisms, as well as I think the foundation of all systems being leadership governance frameworks that advance the objective of a health system. So when we speak about the role of health information systems in healthcare, we generally speak about the manner in which the technologies and the various ones that I'll speak to in the next slide assist us in understanding the context for the patient, the context of the service delivery platform, the objective of the health system in order to deliver improved health outcomes. And the importance of either introducing new health information systems or actually designing new ones is whether or not you are able to bring that data for decision making. Now, there are many stakeholders that are involved in order for you to be able to bring the right minds together, understand the data needs of the system from all the different players, from workforce to tech, support, as well as, of course, the users. And for managers as well as clinicians to be able to make decisions with the data that you generate, you need to be clear about the data needs. So where in the clinical process flow are they going to be taking some of your data products in order to inform their decisions, whether it is a strategic decision that they need to make in terms of thinking long term, whether it's operational about day-to-day practice, or where it's just around patient experience. And so as we think around informing the culture of data within organizations, you need to have an idea of what platform of service delivery you're thinking about and the complexity of information that's required in order to support decision making. All right, so I've got two particular frameworks that I largely bring our teams to. The first, on your left, really talks about the processes around what happens within a health information management unit or a monitoring and evaluation directorate. There are inputs, there are processes, and there are outputs. And within this framework, we speak about what resources are required for a health information system to function optimally, and in terms of processes, what kind of measurements we're trying to allocate to activity, and whether or not the data sources help us make those indicators meaningful for decision making. Then, of course, we have to craft some sort of data management process that generates the right information products, and ultimately they should be disseminated, particularly for use. Otherwise, you just have a lot of information that sits and doesn't really inform a lot of what might need to be information for strategy or operations. Now, the World Health Organization defines health information systems as digital systems that gather and process as well as share data from various sources using open data and effective ICT tools and ensuring ethical use. These systems are crucial for supporting evidence-based decision-making at all levels of healthcare, from individual care to national health policy and global initiatives. Some examples of information systems that are in practice currently are electronic health records for patient care, health facility data, surveillance data, census data, population health data and surveys. And then in general practice, you may find practice management software, remote patient monitoring, as well as clinical decision support processes. On the second diagram there, this is where we start to understand an organization in terms of whether or not they are able to use the data that they have or that they are generating in order to inform service improvement decision making. If you look at this PRISM framework, which was published around 2007 as well, 2009, it speaks about understanding the technical, which is largely what we've spoken about with HIS, determinants of whether or not your information is going to be of quality, it's going to be reliable enough for people to use for decision making. But then, of course, you have to understand the behavioral determinants, whether or not those who are involved in the value chain of data actually have the skills or the motivation to assist with the data management process in order to generate good data products. Then one has to take into consideration, and probably the biggest one, is the organizational context and determinants, one of which is whether or not there are finances for allocating towards health information systems, and whether or not there are governance procedures as well as a culture for data use. We are currently at the interface of trying to move quite quickly with the development of big data in healthcare. And this intersection, especially for low and middle income countries, presents opportunities as well as challenges. The opportunities, of course, involved in improvement in decision-making through predictive analytics and AI, which were also spoken about in the earlier session, enhanced patient care through personalized medicine and evidence-based interventions, and also being able to allocate and optimize resources based on healthcare data outputs. But then we still sit with the issue of data being managed in silos or in various ecosystems and don't talk to each other, particularly in the ICT back end, in order to ensure communication between platforms. We also have concerns around data privacy and security, and of course optimizing the workforce who are part of generating and managing data for decisions, so that they are able to deliver those products effectively. So the most important part in ensuring that an organization adopts a culture of data use is to ensure that the process along which data is generated actually supports the decisions that need to be made along the process, the value chain. For example, one might use health information systems to identify gaps, either in the outcomes of patients or in the general process between health workers working into a health facility, whether it's time-based or output-based, and whether or not they're meeting those objectives. You may also consider that health outcomes may not just necessarily be a decline in a prevalence or caseload of some particular health condition of concern, but you may be interested in, now there's a lot of talk around value-based outcomes, so patient satisfaction, making sure there aren't any readmission rates that you're thinking about, and your health information system can indeed support you in being able to identify where the gaps are operationally and, where possible, strategically to improve that process. So I would like to just give a simple example of how we undertook simple Microsoft-based spreadsheets and a Google form to try to put together a process in order to inform improvement in one dedicated orthopedic theatre list, I beg your pardon. And the process really involved people. So less about the health information systems, but more about bringing the people together. And how we did that was to obviously get direction from the CEO. The need was to reduce the backlog in terms of orthopedics, particularly trauma. And we got all the managers involved with the theatre complex, all the heads of departments, surgery, orthopedics, as well as anesthesia, in order to come to a common agreement of what we'd be measuring and how that measurement would support service improvement. We were able to identify the data needs, being a measurement of all the theatre efficiency indicators that are usually found within the scope of theatre efficiencies, and then to select additional indicators in order to identify where the processes may require optimization. Then we decided to create a platform where the discussion around the data, as well as the activities, the resources, the availability of consumables, of people, etc., were available for the orthopedic theatre to be dedicated. And in so doing, the iterative process, in fact, started allowing for a data culture. So the meeting ended up requiring the data in order to inform the discussion, and the discussion would then prompt service improvement suggestions from both nursing and physicians alike. And once again, bringing to front of mind the fact that all the pillars of the health system need to be strengthened in order to optimize the outcomes, one of which being the reduction of financial risk for health users. Using information across all those pillars may help us rethink how to approach this conversation around the NHI or universal health coverage to support more access for services, but doing so in an efficient manner, and also taking into consideration that we are a resource-limited context. So I think there is a lot of possibility and opportunity to use highly technological advances in our settings. But before we do so, and before we go through a lot of resources implementing high-tech solutions, I think the starting point is to know where the department or the organization hopes to go in terms of health outcomes and operational efficiencies, understand the data needs of all the healthcare providers involved in the delivery of health services at the appropriate level of care, and then designing the entire health information system and its processes to actually meet those needs so that the right decisions can be made by the right people for the community that they serve. Thank you.
Thank you very much, Dr. Maimala. I hope I'm pronouncing it correctly. So to indicate just how important health information systems are from the talk that Dr. Maimala has given, if you can ask ChatGPT just now who your mother is, just now, you will have a name for your mother. ChatGPT gave me my mother as Margaret Mwale. I ain't my mother. So why is HIS important? Garbage in, garbage out. So we need to build our own repositories. And if you are going to build those repositories, we are going to base our decisions for AI in healthcare, we need HIS to be in place. Our next speaker is going to talk us about robotics in surgery. This is Dr. Shafika Mayet. I hope I'm pronouncing it correctly. She's an anesthesiologist from Rahima Mosa Mother and Child Hospital, where she's heading the department there, and she's general anesthetics. So we are going to follow up with this talk, robotics and anesthesia.
Good morning, everyone. It's actually not robotics in anesthesia. That was on Sunday. It's actually robotics in healthcare systems. So I'm actually more fundi in robotics in surgery for anesthesia for that rather than healthcare systems, but I'm going to give this a bash. Thank you for the introduction. So we always thought the capacity to be human was to have compassion, empathy, and care. However, we now know that it's merely just our ability to select the squares with traffic lights. And so that's what makes us human and not robots, right? Having said that, Singularity Hub is an exponential university that looks at AI and technologies and are even available in South Africa. So they came up with this very interesting scenario. So you have a really sick kid, right? You have two options with this really sick child. The first option is, do you take the child to a traditional hospital where we have the systems we have in place right now? So human medical staff, human concierge, human nurses, what we have right now. And they tell you the chance of survival for your child is 90%. Now, your other alternative is to choose a robotic track. So when you enter into here, it's a factory-like setting. You have robotic nurses, robotic doctors, but long-term trials have shown that if you enter the robotic track, your child has a 95% chance of getting better as opposed to the 90% in a traditional hospital. So this is what it would look like. So there would be your robotic doctors, your robotic theaters, robotic nurses, robotic concierge, robotic bedside assistants. I want to leave you with this right now. Do you think we are ready for such a system? On the 28th of May, 2024, just a few months ago, in Tsinghua University, China opened its first AI hospital to treat patients in a virtual world. And they reckon that 10,000 patients can be treated in a few days, whereas human doctors would take 2 years to do that. So let me go back to the previous slide. These are not AI-generated pictures. These are actual pictures from the university hospital in China. Yes, this is exactly where we're at right now. Let's move to the past. Have all of you seen iRobot or heard of iRobot with Will Smith? Well, it comes from Isaac Asimov. And Isaac Asimov was a science fiction writer back in the 1930s and 1940s. And he came up with 3 laws of robotics back then already. So what did he say in the 1930s and 40s? He said, a robot may not harm a human through action or inaction and allow a human to come to harm. So the first principle of ethics, do no harm. The second thing he said back in the 1930s and 40s was, a robot must obey the orders given by human beings, except when it is in conflict with the first law. And the third thing he said is, a robot must protect its own existence as long as it doesn't conflict with the first and second laws. So keep in mind that this was done in the 1930s and 40s. And for me, these are relevant ethical issues even today. So let's cast our eyes back to the COVID pandemic. Some of the challenges during COVID were staff shortages, staff burnout, decreased need for patient contact because of the infection control risks, the burnout, the fatigue, compassion. Rural areas had disparities, so urban areas had more resources than rural areas. There were resource limitations in every sector of healthcare, and there was a total lack of infrastructure, with field hospitals coming up in the UK, in America, in South Africa, and everywhere else. These were challenges that were universal and international. So some of the answers in more well-to-do countries were to develop robotic interventions and make robots do the work of human beings. Just look at this slide and take it into consideration. Because in my next slide, I'm just going to summarize what I've said so far. The first thing is the human comes first. And then let's go back to that slide. These were challenges that not only existed during COVID in South Africa and in Africa, these are challenges that exist currently. And in Bruce Picard's book, he even highlights that about 90 to 95% of people in Africa right now have no access to safe surgery. More people die from surgical complications than TB, malaria, and HIV. So these are things to take into consideration when we move on in a robotic healthcare system. So let's move on to the future. So Carolyn's talked about the future a little bit and what we need to innovate. However, when we're innovating for health in the future, we need to remember that COVID might have just been the beginning of what bigger global pandemics of historic proportions can bring. The second thing is the type of collaboration we will have in future healthcare will not just be governmental systems at a departmental level, a local level, and a national level, but should include the organizations that are involved in healthcare and exponential medicine. We also know they need to incorporate the vast array of digital technologies, access, and analytics. And remember, what we term the patient in an area of robotic healthcare systems is now becoming dehumanized, and they're now calling it a consumer. I have a bit of a problem with that, okay? But your consumer is globally connected, is intelligent, and has knowledge at their fingertips. The other thing about future healthcare is we're not just about delivering a service, but it needs to be value-based. It needs to be not just disease care, but prevention and well-being. So there is this shift. So there's this complete contradiction. On the one hand, we have these machines that are involved, but on the other, we need the care and the humanity. So where exactly are robots in healthcare currently? So every presentation has got a busy slide, and this is my one that I'm apologizing for right now. So service robots. So service robots are ones that are involved in your food preparation, in drug delivery, drones that would deliver medicines to impoverished areas and difficult to reach areas. The next area would be the assistive robots. So these are ones that help with orthotics, prosthesis, lifting wheelchairs, and even lifting heavy patients. Another area would be your socially assistive robots. So these are robots that are involved, that can be companions, involved with nursing and other support. Then tele-robots for telemedicine and in that sphere. And the last one is interventional robots. So these are the ones that are involved in surgery, in radiation therapy, in artificial organs, and that area. Okay, so just look at this slide. The big red picture would be your nanorobots. So nanorobots are little robotic capsules that can be inserted into the human body for diagnostic or therapeutic purposes. So this could lead to more targeted therapies with less systemic side effects and better outcomes. The other areas would be at the bedside, care for the elderly, or even in OT and physio. In anesthesia, some of the robots that have come to being are McSleepy. So McSleepy uses a closed-loop system, and it involves targeted anesthetic control, where analgesia is monitored as well as our normal general anesthetic monitoring systems. And in 2010, McSleepy met Da Vinci. So Da Vinci is the surgical robot that we currently use for a lot of our abdominal pelvic surgery and other surgery, and a robotic anesthetic as well as a robotic surgery were performed using McSleepy and Da Vinci. The thing is, just remember, none of this was robotic in the true sense. They were still computer-assisted devices that are human-controlled. The Kepler intubation system is an endoscopic intubation system where a joystick is used, and that is how intubation is directed, again by the human hand. The Magellan is a regional anesthetic device that is also where the ultrasound probe is still controlled by humans, but the needle placement is via the robot. So all of this is driven by AI. So what is AI? So basically AI simulates human intelligence. It's computer programming that includes for reasoning, learning, problem solving, and understanding new information. The problem is, or the advantage is, when AI becomes deep learning. So what is deep learning? Deep learning is when artificial intelligence, which simulates human intelligence, uses its own information capacity to teach itself and reach newer heights. There's also a difference between robotics and artificial intelligence. So I like to think of it as the brains versus the brawn, where artificial intelligence is the brains behind it, and the robot is the brawn or the body behind the entire system. They've already touched on why robots in healthcare. It's obvious that we need precision, consistency, and over a long period of time, it might even be cost effective. There's less infection rates and less fatigue. The disadvantages are obvious. The skills and the training required and the learning curve is massive and steep. There are ethical and legal challenges as well as the environmental impact that everybody have been talking about today. And then there's challenges with patient trust. We touched on the dehumanization of care early on. This is my tip for today. If you want to put your money anywhere, put it into AI intelligence systems. I personally haven't done it yet, but it's something I'm looking into. Okay, and the reason I say this is, if you look in 2021 worldwide, $11 billion was spent on AI. The prediction for 2030 is $187 billion is what the cost of AI will be by then. So it's an exponential increase. Why this increase in AI? Because of the precision and the cost effectiveness over a long period of time. So what are some of the things that AI has touched in medicine so far? If you look at this study from 2017, 129,450 images of skin cancer were fed into an AI system. With covering over 2,000 different skin conditions. I personally didn't know there were over 2,000 skin conditions until I read this article. However, they then took this information and asked the deep neural network or the computer algorithm to diagnose what these biopsies showed and what the results would be. They then took 21 board-certified dermatologists to do the same thing, and the answers were equivocal. So we're actually at the point where, will the algorithm do better than us? The other one would be the AI-generated intelligence on chest radiographs. And again, the AI system did just as well as human emergency physicians. What about in anesthesia, since most of us are anesthesiologists sitting here? So they retrospectively did a study where over 13,000 patients had post-induction hypotension within 10 minutes of induction. They then took the parameters, the pre-op parameters, fed it into the AI algorithm, and asked the AI algorithm to predict the onset of post-induction hypotension. And the positive predictive value here was 96%. So you can see there are multiple uses of AI in every sphere of healthcare. What about us in Africa? So we know in Africa, with the shortage of diagnosis and treatment, and because of our systemic failures, that impacts the way we treat and the effectiveness with which we treat. So the USAID agency has stated that there definitely is a role for AI in anesthesia, in Africa. If we look at the busy slide again, we see the red dots on the slide is where AI startups are already working in Africa. In approximately over 75 sectors, AI strategies and structures are being implemented. The African Union recognized the need for AI, so they have now come up with the document that I've put up, where they've now trying to structure a plan with Vision 2063. They look at agriculture AI, AI in healthcare, mining, and every sector of education and finance. What are some of the challenges they've highlighted? So if we implement AI right now, we know we've got outdated infrastructure, limited expertise, inadequate infrastructure, and urban and rural barriers. So if I give you an example, I work at Helen Joseph Hospital, where a robot was put into the pharmacy to assist with the number of scripts that they have. And just yesterday, we were told by the pharmacy department that the robot is this massive thing in our workflow space. We have over 900 scripts to do on a daily basis, and the robot can't cope, and it's in our flow space. So it's basically an obstruction to the way we work. So these are the sort of things we need to look at when implementing AI in Africa. Some of the frontiers that this document looked at and they see a place for is definitely so important to Africa. Telemedicine, remote surgery robotically where expertise is available and taking it to areas where it isn't available, with drug doses and with drug delivery, diagnostics of TB, malaria, and HIV. Even they spoke about the health information systems this morning, so in healthcare automation and maybe even increasing our workforce. So could AI be the silver bullet to revolutionize care in Africa, where there's either a lack of infrastructure? So should our next infrastructure be an AI computer-based infrastructure, because nothing or very little exists? And my second question is Africa ready for this explosion? So if we look at healthcare systems, we know about the traditional healthcare systems. It's the government, it's the players and the role players in health. However, when we look at healthcare systems in the age of AI, we need to take into consideration the infrastructure, but this doesn't only involve bricks and mortar. It's your internet, your cloud management systems, the connectivity, data centers, broadband access. What about a good, reasonable, responsible power supply? We need policies and regulations, and currently Dubai is one of the countries that have developed a department of AI, and they even have a minister of AI. So what about data privacy, accountability of what we're doing, and the ethical and legal standards? Ongoing education and training are part of healthcare systems in AI, and financial support, even including public awareness and trust. So Africa, are we ready? Some of the solutions they come up with in this document are public-private partnerships and developmental banks putting money into setting up systems that are already AI-based, investing in communication and telecoms. Everybody walks around with a cell phone. Can we use that more effectively? We need renewable energy sources with policy and regulations, ongoing education and training, creating a public awareness, and finance. So here's my question again. Africa, are we ready for the AI explosion? Well, we know in Africa we live with the concept of Ubuntu, and I tried to look up other words in other languages for Ubuntu, but the bottom line is, even if we try and explain it, it's a deep inner humanity and caring for each other. It encompasses the community, the tribes, the people and the friends that surround an individual. So unlike a Western ideology of me, myself, I, and my autonomy, it's an entire community-based thing. When implementing AI in Africa, we need to build trust amongst people. We need to take into consideration these cultural aspects. Our informed consent forms would have to include the robotic capabilities and the advantages, the disadvantages, the risks and the benefits of the robots that we're implementing. Above and all, beyond that, we also need to make sure that our robots are the oversight of humans in the robotic interaction. So there's always a human overseeing the robotic interaction. The other thing is the robot should complement the work of human beings. And most importantly for me is the involvement of patient-centered care and shared decision-making. We also need accountability and ethical, responsible programming. Now sit back and relax everyone, because we're in medicine, we're laggards. We're slow to adopt things and we take a while to do this. The reason for this is because standards of care and safety are so important for us in medicine. So traditionally, we're slow to change, and AI is coming, but not as fast as most sectors outside of medicine. The evidence base for the use of robots in healthcare is definitely expanding, and robots are being used across a wide range of specialities and settings. So I want to leave you with this. The future of robots lie in remote presence and the ability to carry out tasks in challenging environments. This will depend on a robust infrastructure, network capabilities, and successful adoption, allowing for what I started off with at the beginning, what makes us human. No, it is not the ability to identify traffic lights in boxes. It is the care, the compassion, and the value we bring in our workplace on a daily basis. Thank you.
Thank you very much, Dr. Mayet. And the passion you have for the topic is evident in your voice. The future of healthcare indeed will be radically different from what you know today. And what caught my attention is how much money this market is going to be in 2030. So you can imagine who else is looking in this department. So we have a chance to be part of the future and control the narrative with what we do today. Our next presentation is done by Professor Pradeep Kumar. And Professor Kumar is a personal professor of pharmaceutical sciences at the Department of Pharmacy and Pharmacology. He's going to talk to us about innovative African drug delivery designs.
Thank you, Chair, and good morning, everyone. And thank you, Dr. Mayat, for introducing half the topic already. So she said drug delivery, she said pharmacy, and those robots going into the bloodstream. So we make those robots that go into the bloodstream. So thank you for that. And I'm not a doctor, I'm a pharmacist. So yeah, so I'm the outlier. So that's my only disclaimer, actually. Okay, so yeah, so I saw the topic of the session saying innovations in the face of resource limitations. Okay, so that's why I designed my presentation on that one. So I'm Pradeep Kumar, and I belong to a drug delivery platform which is at WITS, and so we have a very big unit established by Prof. Pillay. He passed away sadly in 2020, but we still are doing very well, and we're going very strong. So today I will be presenting so it says resource limitation, okay? So let's say if we have, so we as pharmacists start with starch as the first thing that goes into tablets, okay? Starch is very, very basic thing, so in Africa when we say resource limitations, and we mention resource limitation and starch on both sides, the thing is we are not short of starch, okay? Tapioca starch is there. So we can use our resources to the full, and we can make advanced drug delivery designs with innovations. So we have in our unit like 43 patents already 38 granted and 5 in process. So it's a very big platform, and we developed in South Africa for Africa actually, and so I'll present 3 very basic carbohydrate polymers. Okay, so we call them polymers, but they are very, very basic systems: alginate, chitosan, and pectin, and then how they are used for drug delivery, tissue engineering, or regenerative medicine, wound dressings, 3D bioprinting or printing, as well as nanomedicine. So with using very basic excipients and polymers and biomaterials, which can actually produce advanced delivery designs with very specialized applications. So alginate is obtained from sea kelp. Okay, so it's a waste material. You can grow. Gold Coast in South Africa has very amazing alginate with very high manuronic acid. So if you can see, so there are, I won't bore you much about this, but there are structures, and then this very long chain, but it's very amazing biomaterial in terms of its very high molecular weight. It swells very well, and is very easily processable. It's soluble in water if it's processed very well. So it is so if it's soluble in water and we inject in the body, so it dissolves immediately, or we make a tablet, it dissolves immediately. So we have to do something to keep it intact for a very, very long time. So what we usually do is we use calcium, very easy, calcium carbonate, calcium chloride, any calcium salt mixed with alginate makes a gel. Okay, so it's an egg box system. So it's a solution, you add calcium, it makes egg box, you add more, and then it makes a very big zipper dimer, is like a scaffold. Okay, so it makes a bead. I don't know if you have seen beads in by the kids play with those beads. They're alginate beads actually. Okay, and then these can be used for drug delivery systems. They incorporate drug very well, very high dosing, 70-80% dose can be there, and you can extend the release of the drug for a month. Okay, so everyone was showing AI, so I thought let me also bring some molecular modeling. So this is also shows if calcium chloride is not there, then you can use barium chloride, calcium, zinc, any divalent ion that is available in the pharmacy, we can use to make a delivery system using simple alginates. So there are many more systems that we can be used, but barium is the one that we have found to be work very well. So we made super stable nanoparticles for TB intervention. So it's so if you can see I will just show without the surfactant. So if you use sunlight that we use for washing dishes, okay, that's a surfactant. So if you add sunlight to calcium chloride and alginate, the nanoparticle size go from 2000 to 173. So it becomes very small nanoparticles, and it can go to, I don't know, even brain. Okay, it can cross the blood-brain barrier. It can cross any barrier in the body, as well as, and it's very stable. We call it super stable because they are very stable. And sorry. So and it can be of any size that we want. So if you change the cross-linking and the sunlight concentration, then you can change the size of the system. Another one is for dental use. Okay, I'm presenting where we can use these biomaterials. So for dental use, so we had a student who did a very amazing study of dental sutures, okay, as well as dental implants, okay, with alginate fiber. They can stay in the mouth cavity for at least 6 months, okay, and if they are ingested, is fine because they are biocompatible. Okay, so biodegradable, biocompatible. So if they can stay there, but if by mistake they are ingested, they are fine, and they have very strong. They are as strong as steel. Okay, and then they can be extended, and they can be tied in several knots in one go. Okay, so they are very amazing fibers. Okay, so there is. I will also say the non-conventional biomedical use. So drugs themselves act as plasticizer to give them that steel strength. Okay. Again, another one was for arthritis. Okay, alginate mixed with a drug makes a very big good combination for, let's say, for example, 4-aminosalicylic acid with alginate makes a gel, and that gel, when injected into an arthritic joint, it provides lubrication. It can stay there for 2 years. Okay, it's much cheaper than hyaluronic acid, maybe 100 times cheaper than hyaluronic acid. That is, and hyaluronic acid only lasts for at 6 months. Okay, this lasts for 2 years, and it is highly biodegradable. And the last one for alginate is 3D bioprinting. So you can print 3D structures or what you say 3D scaffolds using. So this study was done for bone tissue engineering. We had a rabbit model where we used the bones from the rabbit, put a hole in the rabbit bone, and then put the scaffold in. Within 28 days, the bone healed completely. You cannot even determine where the scaffold was implanted. It was so good because the thing was that we scanned the rabbit's bone, and the thing is and we matched the porosity and the strength of the bone with the scaffold using a 3D bioplotter. This is bioplotter. It's not a bioprinter. It's like a 3D bioplotter. It's like it costs 5 to 6 million rands. But it makes amazing scaffolds. We are making brain slices as well as skin using artificial skin using 3D bioplotting. Okay, I'll go to the next biomaterial, which is pectin. Pectin is obtained from where? Any idea where pectin is used in baking? Pectin is used in baking. It is from apple skin. Apple skin, grape skin, any skin of a fruit can give you a very good amount of pectin. It's a very, very complex biomaterial. The structure is not yet fully known, okay, but you can still use it for many, many applications. I just was showing off this structure here, but you can easily mix it with cross-linking agents again and make wafers, okay. The lyophilized wafers of pectin dissolves in half a second. 0.48 second is the time of dissolution of a pectin wafer. Okay, you cannot photo it ever. So you have to make a video and then take a screenshot of the video, because you cannot photograph the speed of disintegration of a wafer. 0.48 seconds is fastest dissolving wafer. So, but it's amazing wafer in terms of pediatrics, geriatrics, as well as many applications of delivering even peptide drugs. You can also conjugate polyphenol, so like we did with alginate, with aminosalicylic acid for arthritis. In the case of pectin, you can conjugate it with a polyphenol. Polyphenol is a drug from, let's say, naringenin, curcumin. All of these are polyphenols. They're very good antioxidants, but the solubility is a very, very big problem. So we use pectin actually to increase the solubility. You can look at the solubility here and look at the solubility here. So it makes the drug very soluble and it's very, very effective. So you can use 5% of drug instead of, so if you are using 100 milligram of drug without pectin, you can use 5 milligram, just 5 milligram. So the side effects are very, very low, and it is very, very effective in terms, efficient and effective delivery system when using a pectin-based conjugate. We made this one for anti-HIV proteosaccharide. So mucins, the mucus that we have in our body is very interactive to pectin. So we use the mucin actually itself to make a biomaterial system. So you make a biomaterial system with pectin and punch it into a tablet. As simple as that. So using bio and material, okay, so the biological material as a biomaterial to make an advanced system which can release drug for 28 days. Okay, so it can make a scaffold, implant into the body, release the drug for 28 days, and it's completely biocompatible, okay, and biodegradable. So over time it degrades with the same speed as of the release of the system. So the last one is chitosan. Okay, so I love this molecule. I worked on this molecule for last maybe 15 years. Okay, so it is obtained from crustaceans. I don't know if you have ever eat crabs or crustaceans. So the shell, there is a waste material. So the waste material of the shells gives us chitosan. It is actually the second most abundant polysaccharide on the planet after cellulose. It's an amazing molecule in terms of it can be cross-linked. It is bioactive. It has its own wound healing properties. It adheres to it attaches to the biological system very well, and it can be 3D printable, okay, as well as some biocompatible. Okay, so biodegradability, I say biodegradable, not I say cross here. It is biodegradable, but depending on where you implant in the body. So there were several systems that we prepared with chitosan. For this one was a system for mucoadhesive drug delivery system. So the tablet goes into the stomach or intestine and it sticks there for many days actually. Okay, so it can be stick there for many days. You can change by changing the amount of cysteine. So we have N-cysteine here. So you can change the amount of cysteine and then it can stay there for very, very long time. And then provides a delivery for extended days. So that's a mucoadhesive system. We also used chitosan for oral delivery of insulin. Okay, so insulin, everyone says insulin cannot be delivered orally. Okay, the acid in the stomach destroys the insulin, but it's not true anymore. So you can add the insulin to mucoadhesive nanoparticles of chitosan and can be delivered to the stomach. It releases within 90 minutes, so that's the lag time that we are looking into. But if you know when you're having food or you're having lunch at 1:30, you can take the tablet at maybe say 12, and then so its tablet is no injection. So while we're having the session now, you can before the start of the session you can take the tablet. By the lunch time, the insulin will have its own effect. So it's an amazing system, and it is mucoadhesive as well. This was a very high functionality targeting. So chitosan can be used to target melanoma, cancers. Okay, so out of 25, I think we tried different polymer systems, very synthetic as well as natural systems. Chitosan came out to be the best. And what we found is 5-fluorouracil drug that we used. It has a very good balance in terms of functionalization. So if you overdo things, it will not work. Or if you underdo things, it will not work. You have to have a very good balance of the size as well as the functionality of the nanoparticle system. If we achieve that one, it's very effective in anti-cancer medication, and it's very, very cost effective. So in terms of, because it's lower drug dose. So all the systems that we are preparing, advanced drug delivery system that we are preparing in our platform, the good thing with them is the dose is very low. Okay, instead of using 500 milligram paracetamol, let's say for example, you can have the same effect in 75 milligram. Because the thing is you target it, you provide it efficiently as well as other aspects. You can we made artificial blood vessels. Okay, so we implanted these blood vessels in the rats, and the thing is amazing results were obtained. They replace the blood vessels, and blood vessels grow actually for over a very extended period of time. We could only do it for 6 weeks, not more than 6 weeks, because ethics doesn't allow. But they are very they mimic the blood vessels, and it is very easy to make. It's not very difficult to make in the labs, because you just need patience for this one, because it's a lot of drawing and lyophilization. Another one was colonic drug delivery to the colon. So it releases the drug after, you can see after how many hours it releases the drug here, after 8 hours something, and then it releases. So it is a targeted system for the colon. So it won't release the drug in the stomach or upper intestine, small intestine. It will only release the drug in the colon, and it's an extended or delayed release delivery system using chitosan again. There is some, and the mechanism of action is the enzymes react with the polymers, and they release the drug. And this one is the fluid absorptive chitosan platform. So we use chitosan and alginate together to make a wound dressing system. So it's a sprinkle system. So it's a powder. As soon as you sprinkle the powder over the wound, it makes a film, and that film stays there for 72 hours. You don't have to wash it away. It absorbs. It's a bioresorb, so you don't have to remove there is no secondary injury for removal of the dressing. It bioresorbable. It resorbs in the skin, and you can apply more if it's required, because we have found that in 4 days against 14 days control, the wound heals and seals within 4 days. So it's very effective delivery system. I think we have a patent on that as well. And for the last one is, I think, the TB intervention for liposaccharide matrices. So you can use soy lecithin. Soy lecithin is available at Dis-Chem, half a kilo in 60 rands. And the cost of chitosan is a kilo for 80 rands. and you can make in 2 kilos of that stuff, let's say in various ratios, 1:1 ratios, you can make, I don't know how many, supply for 5 years for one patient. So in 80 plus 16, 140 rand, and it's just simple mixing. It's not advanced mixing. It's just simple mixing, and you need we did an MRI of this is MRI of the tablet. Okay, so we have a machine that does MRI of a tablet and shows how the hydration works. And the last one, okay, so the last one is cryosponges. My very niche area is neurotrauma, so I work on neurotrauma, and we have spinal cord injury scaffolds which have been very successful in last 12 years, from injury to complete recovery of the neural spine from complete transaction. And here I show with very small change in functionality, OCH3, CHO, or COH, C, H and O, only 3 things. We just move them around, carboxylic acid, aldehyde and methoxy group, they change the shape of the scaffold. And how they change the shape of the scaffold, the neurites grow, and the scaffold actually provides the platform for the neurons to grow as well as meet and provide the regeneration. So it's a very successful platform. We are now actually in our preclinical studies. Preclinical studies are done. We are in large animal models now, and it works very well. It's also based on chitosan, and we have another one on collagen and elastin, which works very well as well. So there are some examples. You can use the same one for pristine nanoparticles for neural tissue engineering. I just give some anti-HIV drug delivery. Same alginate chitosan. This one is for Parkinson's intervention, nanoparticles for Parkinson's disease. Then again we have for nose to brain delivery. So you can sprinkle the nanoparticles in the nose and they go through the olfactory lobe to the brain. It's very effective in terms of blood-brain barrier intervention as well as Parkinson's and Alzheimer's. Gel and gum we use for baking as well. Xanthan we use for baking. They can be used for hydrogels for controlled drug delivery. And we had an amazing project where we used polyphenols again with gel and gum. So these are our funders as well as some friendly universities that I would like to mention. And thank you for listening. Thank you.
Thank you so much, Pradeep. Very interesting. So we heard about efficiency delivery of molecules with the same effect, and we have targeted molecule delivery for a quick effect, and a lot of other issues that we have heard from Mr. Pradeep. But what is the impact to our patient and to the healthcare system? Is something that we should keep on thinking about. It's innovation, but what is the impact? Because as the talk have been happening since morning, it's about human, it's about our people, it's about the health of our society. So the next speaker is Lebohang Toko. She is a drone pilot from South African National Blood Service. She is a technical support officer in the transfusion medicine department. Currently, she's training to obtain her private pilot license at the African Aviation Academy at Rana Airport. She's the first and the only drone pilot at the South African National Blood Service, BloodWIM. You're most welcome for utilization of drones in medicine.
Thank you, Program Director. I'm amongst many doctors and professors. Maybe it's a sign that I should change my profession. I'll be talking about the utilizations of drones in medicine. The South African National Blood Service as well as the Western Cape Blood Service collaborated into trying to figure out how we can contribute in reducing the maternal mortality rate in South Africa. It's just important to note that the South African National Blood Service does play a role in the nationwide distribution of blood. We service 8 out of the 9 provinces, excluding Western Cape, obviously. And to facilitate this, we collaborate with 14 blood bank courier companies, and we also have 2 national courier companies that transport our blood and blood products around the country. But sometimes it's not enough, and we just simply need more coverage. So to put this into perspective, just a personal story, in 2021, I experienced intrauterine death at 36 weeks. I was bleeding internally, and I subsequently needed blood. Fortunately, my gynae at the time was located at Olivedale Hospital, and the closest hospital from there is Sunning Hill. So the turnaround time in terms of me getting my blood products was efficient, and I was able to get my blood in time. But imagine if I was in Tula Sizwe Hospital, where the hospital personnel say it can take up to 18 hours for them to get their blood products. So drone delivery can have a potential to make a significant impact in patient outcomes. So then we introduced the Quantum System Tron, which is our current drone. We needed a drone that could fly far and could fly fast. So the maximum speed of the drone is 180 kilometers an hour, and it has up to a payload of 2 kilograms. So initially, it was said that we could put in 4 units of blood, but upon testing, we realized that when we put 4 units of blood, it moves our center of gravity forward, which makes it nose heavy. So then we reduced it to either 2 or 1 unit of blood. But also, it's a two-way logistic. We can also transport samples, not only blood and blood products. And this cargo hold has the capability to ensure that the blood cold chain is also maintained during flight as well. This is just to give you an overview of our operation and our mission. Because we fly beyond visual line of sight, we need to ensure that we see the mission throughout the duration of the flight. So this is just a picture just to show what we would see in our ground station. It would show the altitude, the wind speed. Our altitude profile is also shown there to make sure that we don't hit trees or go over people's houses and the likes. But this is all done pre-flight. We put it in as a mission. So this is a Wingcopter 189. Unfortunately, our Tron had to be grounded because the manufacturer had discontinued it, so they will no longer be giving us support in terms of software upgrades and the likes. So the best thing was to ground the drone and not use it. And this drone company, it's also a German company, Wingcopter, flies fast as well, flies far as well. And this one is specifically designed for drone delivery. I know countries like Malawi use it, and Ghana use this as well, with Zipline as well. But we thought as an organization, this fit what we wanted best, because it uses cellular mobile networks for command and control with a satellite communication system as a backup, because obviously if you're in a rural space, we do need continuous communication. So this drone can be operated anywhere in the world, but this is subject to Civil Aviation Authority regulations. Currently, they don't allow us to fly the drone autonomously. We need to have a handheld controller at all times in the event that we need to take physical control of the drone. So just to note, in a significant milestone, we as the South African National Blood Service, we obtained our ROC in 2022 as a proof of concept between Sebokeng Hospital and Kopanang Hospital. We cover a distance of 10 kilometers, and then we have a handover procedure at a distance of 5. This really will help us in wanting to expand the project to your rural areas such as KZN, such as the Eastern Cape, such as the Western Province. So hopefully going forward, we can apply for a longer route and fly for higher altitudes as well. So just to note the hurdles, this project was not, we had our fair share of hurdles. Securing the approval of the Civil Aviation Authority was a significant hurdle. We needed to do a series of audits just to see if they trust the technology that was being presented at the time. And another hurdle was the landowner permissions in Sebokeng and the Sedibeng area. According to the Civil Aviation Authority, you need to ask for permission from every landowner that you'll be flying over. It's not like your helicopters where they just fly. They don't really come and ask permission from our homes, but we needed to do that and knock on each and every homeowner and ask for permission for that. So that's one of the things we did, and including the hospital, we needed to collaborate with both hospitals, Sebokeng and Kopanong. Another hurdle that we experienced, we use ground stations that are shipping containers, and one of the things during COVID, we weren't flying, so we had solar panels, we had generators, we had the likes, and they were all stripped. So that's another hurdle, and trying to figure out what is the most cost-effective way of having a ground station that won't cost us a lot of money. So this is just to give you a perspective of how and where and the size of the property owners that we needed to go to. Fortunately for us, the owners didn't open their dogs when we went knocking on their doors. So this is essentially the route that we fly between Kopanong and Sebokeng Hospital. And my next slide is really just going to just give you a brief overview of our operation. It's a video, so if this volume is too loud, can the technical people just take it down a bit, just to be mindful. And yeah, so thank you for the time, and I really hope that the drone project can extend itself to where it's needed in your rural KZN, in your Eastern Capes, and your Western Province. Okay, there's no sound. Thank you.
So thank you very much for that presentation. You might not be a doctor like us, but you're definitely needed to be a doctor in your field, and well done, and all the best in your field. Well, at this moment, we'll open up for questions. I think we got about how many minutes? We got, I think, about 30 minutes. But that's too much, so we can just get the questions we can get. So we can ask any of our presenters from the beginning to the last one. There are two mics, depending on where you're seated. So if you're at the back, there's a mic at the back where you can ask a question for people who are watching us online. And then there's a front one as well. And then when the question is asked, the one who's asked, then who can probably come here and respond, or whichever mic is closer, they can use it. So there's a hand there, please, sir, go ahead.
Yeah, thank you very much, and very interesting. And I saw in the morning on the lineup, and I knew that I was going to be in this room. The first one goes to the speaker who spoke on health information system. I think for me, this is one of the most important things for South Africa today. An idea of a health information system that allows the country to even have a universal health record, regardless of the sector that you are being treated in. And I think for me, this would then be the springboard for us to move towards the use of AI in healthcare. So I just want to hear the speaker's views on the importance of the universal health record for South Africans in the light of the NHI debate. So that's the one thing. And the second thing goes to the speaker who spoke of AI in healthcare. And for me, I think this is where I think doctors in general have taken a step back, and this has been driven by computer nerds and all the people who have interest in computer sciences. Now, I just want to hear the speaker's views on the idea of a combination of clinical leadership and technological leadership in that space, so that we can bring in the medical phase within the AI and its application in smart health. I'm saying this, Kimem, because I'm the CEO of the South African Medical Association, and we are hosting a AI in healthcare on the 29th of November. Yeah, so, and we want to talk about clinical leadership in that space. Thank you very much.
So we can have the two questions answered.
Turn this around so I'm facing you. Thank you so much for that question, and I 100% agree with you that in the absence of knowing what we're dealing with, we are likely to waste a lot of resources, and I think we need to start with the health information systems. I am aware that the National Department of Health, some time ago, probably a decade or so, put together a policy document around mHealth, eHealth, just general health information systems, and how developers or anyone who is introducing new HIS solutions towards any part of the ecosystem should design them in order for them to be adoptable for scale. And in the introduction of getting towards signing off the NHI, I think one of the questions we always ask around innovations and health information systems is this practicable, is this implementable, and is it ready for scale? I know there's a health identity HIS module that's already been implemented, I think just as a registration, HPRS I think it's called. And it's been implemented in a few, I don't think in all of the facilities yet. And the idea is, of course, to link it to identity numbers in order for one identity number to be a health record across the nation. And I think from especially a public health lens, we aren't able to project even what kind of conditions we're likely to see if we don't even know at the moment what we're dealing with. and how our treatment plans are working or not working in terms of health outcomes. And because, you know, in the other diagram I showed, there's so many outcomes we're trying to solve for within the health system. We need to be able to measure whether or not we are achieving those, and if we're not, how to redirect our efforts in order to do so. So I think health information systems are essential. Health governance frameworks are definitely important, so everybody knows how to handle the delicacy of health data particularly, and to make sure that it isn't at risk, of course, of data security breaches, as we recently saw with the NHLS incident. So there are a lot of complexities around managing health information systems, but we need to get a lot more robust, and I think adopting new ways of using information for our processes is really essential for us to be able to move forward. Thanks.
Thank you very much. The next question.
Thank you for your question. Can I just recap, because so much has happened from your question till now. So what you were asking is the dynamics between those that are adopting AI and us in the medical profession, basically. Is that right? Yeah. Okay, so the importance of clinical leadership and technological leadership. I think our biggest problem right now is that we're all technologically challenged here. Every single one of us sitting here. Excel, Word, that is probably where our knowledge of computers ends. We don't know coding, we don't know programming, we don't know data analytics and analysis. And I think the future would be to introduce things like that into our undergraduate medical curriculum so that we're not handicapped and technologically challenged, so that we also have some sort of control into these processes and we're not just blindly being led by other people. And I spoke about the concept of laggards. I don't know if you remember, and that is a proper concept that exists, and it almost comes from the environmental impact on health, where we're in the medical profession are laggards. And so I adopted that from the environmental space, and I've put it into the technology and AI space, and we are all laggards sitting here. I'm the first one here. I think my knowledge of coding stops at the spelling of the word coding. And I'd like to just check, how many of you know anything about data processing, programming, and coding sitting here? So 3. So most of you know how to code. Okay, so then that's a lot more than, I think if we had a bigger audience, we're a lot more biased, because the people sitting in here right now probably have an added vested interest in this. But if we took a poll across the entire AAAC delegates right now, you would probably be the only ones who know about coding and programming. So I think it's time we didn't allow those decisions to be in the hands of only those who are in the field, and we start getting involved in that space. I think it's very important going forward, and I really, really believe that it starts at grassroots level. So maybe not even universities, but universally in education from grade 1 upwards all the way. Right now, coding in schools available to those who go to a Curo school and upwards, not really in the government space, firstly, and secondly, it's by people who can afford to send their kids to these programs privately and pay exorbitant fees for these. So these are things we need to really, really start thinking about, the way we think about these things in the bigger picture. We talk about the affordable, accessible, available healthcare. We need to start thinking of technology in that way, because that is what is going to define us going forward. And I really, really, really believe, and I spoke about it in my talk, that Africa, we have a lack of infrastructure to begin with. So would that not be even easier to start implementing these things? Because we're starting from the grass, from nothing upwards. So if we start developing our systems in that way from the get-go, it might just be the way to progress. I know there's a lot more. We know all the challenges I spoke about. but it might be one way to reinvent and rethink the way we think about AI in Africa and in our spaces. I hope that answers your question. My disclaimer really is I've just done a bioethics degree, and that's where my interest in AI and ethics and robotics actually came. So I'm no expert, but I do speak more from an ethical mouthpiece and just a more human way of looking at this. I hope that that answers you.
Thank you very much. Any other question, please? Okay, we can have a gentleman there.
Thank you for the lovely session. Really enjoyed it. My question goes to the speaker who spoke about health information, specifically the study case you mentioned about the CMJ. I just wanted to find out, did you evaluate after the implementation of that health information, and how has it been doing? Because we were initially involved in allocating extra theater for the orthopedic list, even pulling up some manpower to come over the weekend to do the extra shift so that they can clear up the backlog. But what I found lacking when I speak to the individual that are doing the actual job on the ground was that there was a discrepancy between how are we doing, and that's what they were always asking, that we thought this was just an implementation to relieve the backlog, and now it's been almost close to a year now it's continuing. So I just wanted to find the feedback from that. And then the second question is to the Lebohang. So can that drone fly at night? And how many turnaround time has it done between Sebokeng and Kopanong Hospital? Thank you.
Thank you for that very specific question. So from the health information perspective, okay, so the project was actually meant to be a 6-month project in order to relieve the backlog. But one of the inputs that we got in terms of just general backlog covering 5 years really is that with the number of theaters that were running, particularly overnight, the orthopedics cases would have to, step aside sort of for the traumas, the vasculars, and so they would generally just keep on increasing their backlog. And so the thought was, if we change it from just a short-term intervention to a more sustainable solution for them to run a dedicated theater, then they wouldn't actually have any backlogs to begin with once they've cleared their backlogs. I think the ongoing resource challenges regarding nurses specifically for theater has been probably the biggest stop-start factor in our ability to push through the numbers. Another reason for cancellations that we started to see across actually all the theater complexes is the number of ICU critical care beds post-surgery available. And those impede the ability for the throughput to be as required. But during the time of the project, when we did have enough nurses, or we were able to shift some nurses between other hospitals within the cluster facility to support the project, we generally track hospital efficiency indicators, specifically the bed utilization rate, so the proportion of beds that are occupied at any given time by that particular unit, and we started to see it go down in the orthopedics wards. And we also started to see the length of stay reduce over the time of the project. So that to us also was pinned to the idea that they were going through their cases and were able to release their patients post surgery. I think the issue now, there are spin-offs off of that project, being the ICU beds, etc., and sustained HR and task shifting solutions that we have to think about. But I think the fact that the intervention assisted the department, the orthopedics department, I think was very valuable. And the fact that it was demonstrated in those efficiency indicators was also good. Yeah, thank you.
Okay, let's go ahead.
So yes, the drone can fly at night. We applied for a night rating, so we just put on strobe lights for us to be able to see it at night. And in terms of flights, we've to date only done 6 flights between Sebokeng and hospital. Reason being, as I mentioned, we needed to ground our drones because the manufacturer is no longer producing the Tron. So we're still currently waiting for the Wingcopter. So I think that's one of the challenges. Organizations like Zipline are doing it so well because that's their main focus, is the manufacturing of drones. So we hugely rely on external people, external factors to bring in the drones in the country for us to use. So currently we're not flying.
We had another question.
Joe. Oh, okay. Thank you, everyone. I thought I was an alpha in the room. Okay, nice presentation, and thank you for time taken to prepare. When it comes to the health information systems, my question is, well, my belief is a patient must be centered to their own information. It will empower them to take control of their health when they are more knowledgeable. Are we looking into health systems that will probably govern the patient owning their own information and consenting to who gets that information? Is the health community ready for such? Maybe that's the question to you, my sister. AI. Some of my discussions with the guys in that space, they have always said the people who are leading AI today, the proponents of AI, is obviously from America and the European countries in the main. They started through data mining of this information, and currently within the circles in that space, they are also kind of like conflicting in terms of who controls what happens afterwards. Is it the computer that controls the output, or is it the humans that must control the output? That speaks to the ethics of it, and knowing through time that some of these countries who are mining and who are owning this data tend to use it for wrong reasons. Isn't it time for Africa to probably start also thinking of mining its own data and managing its own data for its own people on our behalf? Thank you very much.
Thank you very much. Another question was asked to Dr. Sorry, I've forgotten the name now. But I would love Dr. Shafika to weigh in as well once the response has been given, because I think bioethics is also touching on HIS.
Thank you for that question. You know, we have debates around what the data source in health actually is, and you're just pointing to that. It is the patient. But many times we use our patient registration system as the first point of where we collect the data. In terms of conversations around allowing or not allowing or facilitating data ownership really by the patient, I know that there are a couple of solutions that exist for a patient-held record that they can share with a health care practitioner or a facility, and they're the ones who provide permissions for practitioners to get access into that information. So those platforms, I think, they do exist. The extent to which they are integrated within our health care platform, I think, is quite minimal. I haven't seen them. It's usually within a hospital group, etc. It's sort of refined within that ecosystem then for individuals to move across different organizations with that patient-held electronic record. Then, of course, if you're thinking about the whole blockchain discussion, there is a lot of discussion around putting those permissions in terms of data use and data privacy along an electronic health record. I've read a couple of articles that think about this in the US, but I haven't heard of any of that discussion in our region yet. So I'm sure there are many, data engineers that can assist us to sort of design these sort of contracts on the blockchain and facilitate that that engagement. But I don't think we are close to that conversation yet. I think the health record is probably closer. The blockchain technology is a little bit further.
Dr. Shafika, your comment, please, on that.
Thank you for your, I don't know if it was a comment or a question, but I'll add on to it. And I really, really agree that, so the problem with ethics and AI is that AI is just moving too fast for ethics to keep up. Therein lies our biggest problem. So we've got our 4 ethical principles, and they're still at the forefront of AI. The problem is, if you're looking at bias and justice and fairness, AI is initially under the control of human beings. So if we start training AI for bias and inequality and inequity, that is how the machine is going to learn. So that is one of the biases that comes up with AI. It's one of the things to think about. I just made a few notes here while you were talking. The next thing is accountability. So the programmers, whoever's involved in doing AI technology, there needs to be accountability from that level downwards. So it's not something that we just say, oh, here's a good algorithm, let's start using it, or here's a good, and this brings me to your comment about Africa. You know, I don't know who it was who said that. I think it was you, that should Africa not be developing their own systems? So I spoke about Ubuntu earlier and about the cultural diversity. So, you know, if we look at Africa versus the West, the principle of autonomy is so different because the buck stops with an individual in a Western civilization. Whereas in Africa, and even in my civilization where I come from, in my background, it's a collective decision that you make. And so if you look at AI and technologies, we need to take into consideration this cultural diversity that we're talking about. And I think these are things that we need to account for and be aware of. So that's the second thing. The third thing is AI has the potential to make decisions autonomously. Okay, and we have no control over it. And I think as a human race, that is what we're worried about. You know, those science fiction movies that we saw where the robots took control, you know, we're all worried about this apocalypse that's going to come. Whether we found it or not, time will tell. But, you know, you spoke about the consequences, and you could take anything. I mean, if you look at, I remember back in the day when the internet was coming around and I was still a medical student, we were told, go to the library instead. Don't use this thing called Google, you know, because it was going to be bad and it was going to be destructive. The next thing is ChatGPT. You know, at the beginning of last year when I started my master's degree, we were told at Stellenbosch University, don't use it, it's bad, you know, and if you use it, and then they started, and even WITS did it, they started introducing courses on responsible usage of ChatGPT, you know, and now we're being told if you're not using chatbots and you're not using technology that's available, you're actually lagging behind. So it's the same thing with your cell phone. It's the same thing with AI. You could be using your cell phone in the deep underworld, or you could be using it in BackaBuddy campaigns, or something to educate people, Zoom platforms where you're educating kids in Malawi or Zambia or anywhere else. So it's what you do with it, and I think all of it boils down to the individual, and it goes back to basic principles of care, ethics, value ethics, and autonomy, beneficence, non-maleficence, and justice. And because AI is for everyone, justice is probably going to be at the top of the list. That's my take on it.
Thank you very much. Thank you very much, everyone. I know I'm just supposed to be the chair, but I've been so much inspired from these presentations that if you can indulge me, I just want to say this about AI. So AI is truly a moving target from what you've seen, and it's moving fast. So that AI train has left the station and it's moving very fast. On that train are the good, the bad, and the ugly. And that train is moving. So do you want to get on that train? If you do, where do you want to be? In the wagons or in the actual seats of that train? If you ask me, I would say you sit in that driving seat. Don't be in the wagons. And let's control what AI is going to do for us. We are still responsible. Even if AI is there, we are the ones responsible. AI will never be held responsible for what it does, but you will. So it's an enabler for all of us. And probably want to say something before we close. The other part is not part of the program, but we'd love to take pictures with our presenters just here at the end, if that's okay.
Thank you so much, Abel. This has been an amazing discussion. Being a doctor, not information technology, AI, it's very interesting. Maybe this will be a question to Caroline and a specialist in AI. So the topic here was resource limited. So where we are already resource limited, I think that is the point. So did we check how much are we going to invest in the system that we have right now, which we have not even exhausted, and how much are we going to invest in AI? Of course, we have to move with the train, but do we have the capacity? So I'm going back to the questions. Is Africa ready? So I need to hear from Caroline and from you.
So I don't think we have a choice. AI is ready, and if we want to remain autonomous, uphold ethics, ensure the data belongs to the people it should belong to and is used appropriately and responsibly, we have to be ready. So all the points made today about how to educate, how to absorb information, how to collaborate, we're never going to be able to learn fast enough at our age to get to the point that we can be multidisciplinary data miners, processors, engineers. So we're going to have to get into the room with people who know how to do it. We need to do that quickly. We've got to make up for all the lost time. And I do believe Africa has more than enough of the right minds. We've just got to get off our seats. We've got to put egos aside, and we've got to have some very fast, hard conversations. So we don't have any choice. We have to be.
So you're asking the same question I asked. Is Africa ready? And again, I think it's the opportunity versus the challenges. So the opportunity is there. The place is there. I said earlier, we in Africa, we stuffed up the technological revolution. So we never really got into the industrial revolution. We're still trying to get that right now. Maybe we should just put that aside in the ideal world and just move on to the next, which is the AI bandwagon. That's what I'm saying. But it's a fine balance between the challenges I spoke about, and finance is right at the top there, along with all the other challenges. But the opportunities are there. And if that AU program where they're looking at funding by 2063, I feel 2063 is just a very long way away. Their vision is for 2063. It's just happening too fast. If we wait till 2063 to implement and have goals that are that long term, we're sitting with the same problem we have right now, which is we missed out and we messed up on the third industrial revolution, and we're going to miss out on the fourth. So yeah, I think we need a collaboration between funders and interested people, and we really need to get involved. And politicians always drive these things, isn't it? It always comes from them. Maybe therein lies the biggest problem. I shouldn't be saying that, but anyway, I didn't say that. But so we need to decrease that from Vision 2063 to like Vision 2030 even. We need shorter term goals than 2063. Thanks.
add one more thought, is that if our youth are the ones who are so tech heavy and knowledgeable, perhaps they also need to be in the room, because they can help us actually adjust and adapt as quickly as they learn. Sometimes we hold our young guys a little bit slowly because we need to understand what's happening and what does that mean, et cetera, et cetera. But I think that vigor, that interest, that innovation is really important in our conversations, because they could assist us in moving as well as we can, but also the governance would obviously just keep things responsible. But our young guys really need to be part of the conversation, I think. Yeah.
Thank you so much. So let's move with this technology in medicine. Okay, we can just give 3 strong. Oh, you want to say something?
Hello, hi. I'm just, I couldn't, there are no words to say. I really came to this conference seeing the Africa and the people, but I really enjoy every part. This particular session is so much. Even though I am coming from England, this is mind-blowing. Just congratulate.
All right. Just 3 strong claps for our presenters. Let's go. Thank you so much. Enjoy your lunch and see you on the next session. All the presenters, please, let's come here for a picture together.